Okay, we're going to be starting off with herpes zoster this afternoon. Dr. Belongia will introduce the topic.
Okay, thank you. Welcome to the afternoon session. There was a time, I think, early in my ACIP term when there wasn't a whole lot going on with herpes zoster, and I can tell you for sure that has changed in a big way. It's very active these days. And we're going to have an extended session this afternoon to talk about what's going on with the work group in preparation for what part of what? Yes, thank you. So the 2017 zoster work group includes Kelly Moore as the other ACIP member and myself, and a number of ex officio and liaison representative members, and a substantial number of invited consultants. And in particular, I want to thank the people who do the lion's share of the work on this, Kathleen Dooling and Rafael Harpaz as our SMEs from CDC. The work group has been very active and very engaged on a number of really key policy issues. Just to review the terms of reference for the work group, the objective is to develop evidence-informed vaccine policy for zoster vaccines. The work group will consider the vaccine and programmatic performance of the currently licensed live attenuated vaccine, which is trade name Zostavax, also referred to as ZVL in these presentations by Merck, and look at the efficacy, safety, and duration of protection of the adjuvanted subunit vaccine, trade name Shingrix or HZSU from GSK, that is currently under FDA review with a decision expected by this fall. And then identify programmatic options for both vaccines that incorporate cost-effectiveness analyses and the potential impact on disease burden in the US. Some recent work group activities have included 28 conference calls since August of 15, a variety of presentations by manufacturers and investigators on effectiveness, safety, immune response, cost effectiveness, as well as programmatic considerations. The work group has looked at the body of evidence regarding both vaccines and has identified key zoster vaccine policy questions and discussed options for addressing them. In addition, there will be upcoming presentations and data for discussion by the work group in the coming months on CDC cost effectiveness analysis and also GSK plans regarding program implementation, particularly vaccine price, efforts to assure series completion because it's a 2-dose vaccine in contrast to Zostavax, efforts to inform and prepare vaccine providers and patients regarding the reactogenicity because it is a more reactogenic vaccine and we can anticipate that, and then efforts to minimize disparities. So there were presentations to ACIP in October of 16 and February of this year, and at the current meeting, we're going to have a presentation on Phase IV studies on Zostavax effectiveness, then a review of Zostavax GRADE, and a presentation by GSK on immunogenicity of the Shingrix vaccine in prior Zostavax recipients, and then a summary of cost-effectiveness analyses to date and considerations for policy decisions in anticipation of a vote in the October 2017 meeting. I'd just like to acknowledge all of the work group members for their active contribution and our CDC SMEs as well as other people at CDC who have contributed to this effort. So at this point, I'll turn it over to Dr. Nikki Klein from Kaiser Northern California, who's going to present on Zostavax effectiveness.
So thank you for the opportunity to present our long-term Zostavax vaccine effectiveness study. So this study is funded by Merck. So this study is a post-licensure commitment to the FDA and the European medical agencies. And here we're presenting our first results on up to 8 years of follow-up, 2007, 2014. So the primary objectives of the study are to estimate the vaccine effectiveness against herpes zoster, or HZ, by age at vaccination and time since vaccination. The secondary objective is to estimate the VE against post-herpetic neuralgia, or PHN, by age at vaccination and time since vaccination. So this study is being conducted within Kaiser Permanente, Northern California, or KPNC as we call it. And we have more than 1 million members who are age 50 years and older, and we have complete electronic healthcare records. So KPNC has offered Zostavax, which I'll be referring to here as with ZVL, free of charge since mid-2006. And since July 2013, KPNC has had a database health prompt for vaccination for those persons age 60 and above. So for the study design is a continuous accrual of people as they become age eligible for ZVL starting in January 2007. And that includes May 2006 for those who are age 60 and above, and March 2011 for those age 50 to 59. So the study cohort, we update it annually to include newly eligible members. So the members are unvaccinated when they enter the study, and then they switch to vaccinated status after they receive ZVL. And then vaccinated and unvaccinated individuals in the study are followed for the occurrence of herpes zoster and PHN. So in terms of the statistical analysis, we estimated VE against incident HZ or separately against PHN using Cox regression. We calculated the VE as 1 minus the hazard ratio. And the Cox regression is on the calendar timeline and stratified by birth year. So the models were also adjusted for demographic characteristics, time-varying comorbidities, immunocompromised status, and the use of health services. So we estimated the VE for vaccinees for the following analyses. We did an overall by time since vaccination, by age of vaccination, and by age of vaccination time since vaccination. I just want to focus for a second on that one because we hypothesized at the time that both time since vaccination and age of vaccination mattered. So we focused on this model, and we did all the other ones as well. And then also by immunocompromised status at the time of vaccination, which I will discuss in a little more detail when I get to those results. So here you can see, this is the uptake of zoster vaccine live within KPNC from 2007 to 2014. Where you can see it's a pretty steady increase in uptake up till 2013 when we had that database health prompt for the vaccine. As you can see, a much sharper increase since that time. The other thing I do want to note is that these are the 50 to 59-year-olds, and we still have very low uptake amongst 50 to 59-year-olds. So for the study population, from January 2007 to December 2014, there were 1.3 million persons who were over the age of 50 years who contributed approximately 5.8 million person years of follow-up. The average duration of follow-up was 4.3 years, and the average duration of vaccinated follow-up was 2.6 years. And of those 1.3 million, 29% received ZVL. And just on the table below, just to see, that was almost 400,000 people, but you can see most of the people were 60 to 69 or 70 to 79-year-olds who were vaccinated. Now for the primary objective of the VE against herpes zoster. For our case definition, we use an HZ diagnosis code accompanied by a prescription for an antiviral medication or a laboratory test positive for varicella zoster virus. We identified nearly 49,000 incident cases of HZ. We reviewed a random sample of charts to verify the definition, found we had a very high positive predictive value, or PPV, of 98%. And these are the cases that are included in the primary analysis. I also just want to mention that we also identified just over 5,900 less certain HZ cases, and these are primary HZ diagnoses without an antiviral prescription. And the PPV for these cases were 86%. Now, these are just included in a sensitivity analysis. They did not contribute to the primary analysis, and I won't discuss them any further. So in this table, you can see the HZ incidence by age groups and vaccine status. You can see there's an increasing in incidence in HZ by age, and what you can also see quite clearly is that the incidence in vaccinated is less than the incidence in the unvaccinated. And I just want to mention that the incidence of our HZ is in keeping with other population-based estimates. So when we look at our overall VE of ZVL against herpes zoster, we can see that we have a VE of 49.1%. You can see the confidence intervals and a significant p-value. Now, these models were adjusted for all of the items listed, all the covariates listed here, but what it's not adjusted for is age of vaccination or time since vaccination. So when we look to see what their time since looking at the VE of ZVL against herpes zoster by time since vaccination, what you can see here is that it's high in the first year, and then it drops from years 1 to 2, and that there's a gradual decrease from year 2, continuing down every year since time since vaccination. By the time we get to 7 to 8 years out, we can see that it's still statistically significant protection, but the confidence intervals are wide due to the smaller number of cases. However, when we look at the VE of ZVL against herpes zoster by age of vaccination, what we actually see is that it's broadly similar across all the age groups, that for those who are age 60 and above, the VE for all the age groups is between 45 and 50%. Now, putting these two together, we have the VE of ZVL by age of vaccination and time since vaccination. So in this graph, I think the thing that's most notable is that at every age group, and here you have the different age groupings at 1 year, they're all grouped together. You can see it for all the age groups, they start off high, they drop fairly dramatically in the second year, and then after this point, there's a gradual decrease for every age group and with every year since vaccination. This right here is the 50 to 59-year-olds. We only had enough time to really do an estimate of the waning for the first 3 years. So finally, this is the VE against ZVL for HC by immunocompromised status at time since vaccination. I just want to make a note that within KPNC, we don't advocate giving ZVL to persons who are immunocompromised, as it is contraindicated, but it is a study done with real-world data, and that people who are immunocompromised do get vaccine on occasion for a variety of reasons. But what we can see here is that there's a couple points to be made on this slide. First of all, you can see that there's good, regardless of low or high, which is equivalent to mild or more serious immunocompromised status, we see that there is substantial protection against herpes zoster with following ZVL. And the other issue is that, and the other point is that the protection is similar when compared to persons who are not immunocompromised when they're vaccinated. So this is, at the time of vaccination, we see equivalent similar protection between those who are and are not immunocompromised. So for the second objective, the VE against PHN. So for our PHN case definition, we began with the nearly 49,000 incident HZ cases and identified those with a PHN diagnosis, which was based on ICD-9 and some internal Kaiser codes. We included codes that were associated with a visit and/or a prescription, and that had occurred 90 days to 1 year after the incident HZ case date. We identified a total of 3,316 PHN cases, which is 6.8%. And the cases with a PHN code for both a visit and a prescription were accepted electronically. We did review a sample of charts to verify that algorithm and had a very high confirmation rate of 96%. And for those PHN cases that only had a visit or a prescription, We reviewed all the charts, and 89% of those were confirmed, and those went into the analysis. So when we look at the incidence of PHN by age group and vaccination status, we can see that again, when you look at the unvaccinated versus the vaccinated incidence, you can see in these crude incidence rates that there are lower incidence rates for the vaccinated when compared with the unvaccinated rates. And then, again, we also see an increasing PHN for each age group as well. For the overall VE of ZVL against PHN, similar to what I told you before about the HZ, we have an overall of 68.7%, which is higher than our, remind you, is 49.1% for overall for HC. Again, this model is not adjusted for age of vaccination or time since vaccination, but it is adjusted for all the other covariates listed. Now, when we look at time since vaccination of VE against PHN, we again see the same, very similar pattern what we saw against HC, in that we have a high VE in the first year. It drops after the first year. Now, after years 2, we can see we see less evidence for waning than we see for HC. I will say that right now our case numbers are much fewer, and I think that right now we'll have to, I think that the verdict's still out because we need to see with more time as the study goes on whether we do see waning or not. Now, when we look at the VE against PHN by age of vaccination groups, again, we see the same similar pattern, that we see the similar protection levels across all age groups, between 60 and 70% roughly for actually all age groups, 50 and above. So I want to, here, this is an average VE against herpes zoster and PHN, so we're putting it all together. And just a note, the difference between average and overall, so overall includes all the cases in the study, but average is actually our best approximation to essentially crudely estimate what is the average VE over 3 or 5 years if we're able to follow everybody in our study for a full 3 years or for a full 5 years. So this is our best estimate for what we think that would be. What we can see here is that for HZ across the age groups, certainly for 60 and above, you see approximately 45 to 50% average VE for 3 and 5 years. And then for PHN, roughly 60 to 70% average VE for 3 and 5 years. So I'm not going to read all this, but this is just to let you know that our results are consistent with clinical trials and other real-world studies. And this is here for your reference, all these different studies listed. You should have them in your packet. So in conclusion, VE against HG was greater than 60% in all age groups in the first year after vaccination. It wanes in the second year in all age groups. Decrease thereafter is gradual. However, by year 7 or 8, it's about half as effective as year 1. But I think importantly, it still is statistically significant, and we think clinically significant at that point. There's still protection left. And there's no clear time point when protection ends. And by that, I mean there's no clear place when then there's an obvious increase in risk that may suggest that it's an obvious time to revaccinate. Our average VE over 5 years following vaccination was 45 to 50% for herpes zoster in all 60-plus age groups. For PHN, 60 to 70% in all 60-plus age groups. So we see less evidence for waning against PHN than herpes zoster. There may be waning, but we can't see it yet, and we just need more time. Persons vaccinated, importantly at age 80 and older, have similar protection against herpes zoster and PHN to younger vaccinees. And then in this study of routine use, persons immunocompromised at the time of vaccination have similar protection against HC and PHN, which I didn't present those data. They are in your packet, but for time reasons, I didn't include that slide, but that table is in your packet. And finally, I'd just like to make a brief note, acknowledge the study team. We've worked really very hard for many years, and in particular, I'd like to acknowledge Roger Baxter, who led the study for many years until his recent death.
Thank you.
Thank you.
I think if everyone agrees, we might go on to the next presentations and then hold questions. Is that agreeable? Is that okay? Thank you very much.
Good afternoon, everyone. My name is Angela Gua. I'm with the Division of Viral Diseases, and I will be presenting on the grading of recommendations, assessment, development, and evaluation, or GRADE, of the live attenuated herpes zoster vaccine. Here's an overview of the GRADE process, which includes the following steps: developing policy questions, considering critical outcomes, reviewing and summarizing evidence of benefits and harms, and evaluating quality of evidence. The herpes zoster work group execution of these steps will be presented here. The remaining steps will be discussed during upcoming presentations. The policy question for consideration is the live attenuated herpes zoster vaccine, referred hereafter as Zoster Vaccine Live or ZVL, safe and effective at preventing herpes zoster? The population of interest is immunocompetent adults aged 50 years and older. The intervention of interest is 1 dose of the live attenuated zoster vaccine. We looked for studies that compared this intervention to placebo or no vaccine. The outcomes the work group considered most important were herpes zoster, post-herpetic neuralgia, duration of protection against herpes zoster, which we defined as protection 4 or more years post-vaccination, severe adverse events, and reactogenicity. Outcomes included in this evidence profile can be divided into benefits and harms. The benefits of prevention of herpes zoster and PHN were deemed critical, and duration of protection considered important. In the harm category, serious adverse events was deemed critical, and reactogenicity considered important. We conducted a systematic review of studies in any language from PubMed, Embase, the Cumulative Index to Nursing and Allied Health Literature, Cochrane, Scopus, and clinicaltrials.gov. We also searched for unpublished and other relevant data. And our initial search terms are listed on the slide. Articles were included if they presented data on herpes zoster live attenuated vaccine and involved immunocompetent adults aged 50 years and older, included data for the relevant intervention, included data relevant to the outcome measures being assessed, and reported primary data. This is a schematic representation of our evidence retrieval process. Working with an expert in library sciences, we identified 1,113 references via database searches. An additional 158 references were identified from clinicaltrials.gov. We also identified an additional 8 references from searching reference lists and reviewing conference abstracts. Titles and abstracts were screened for all 1,279 references, and records were excluded if there was no primary data reported or if the study did not include the population or intervention of interest. Following that step, we conducted full-text screenings of 159 articles, of which 119 were excluded because the study did not report data for the intervention or outcome of interest, was ongoing, had results reported in another study that was reviewed, or were case reports of individual adverse events. And for your reference, the evidence types outlined in the GRADE process are as follows. Evidence type 1, or the highest quality evidence, comes from randomized controlled trials. Type 2 evidence are randomized controlled trials with limitations or exceptionally strong observational studies. Evidence type 3 is assigned to observational studies or randomized trials with notable limitations. And evidence type 4, or the lowest quality of evidence, is assigned to clinical experience and observations, observational studies with important limitations, or randomized trials with major limitations. And now for the grading of the evidence of Zoster Vaccine Live, starting with potential benefits. Outcome number 1 is vaccine efficacy or effectiveness against herpes zoster. There were 2 randomized controlled trials included for assessment. Oxman et al. Reported a randomized controlled trial in adults 60 years and older, also known as the shingles prevention study. Schmader et al. Reported a randomized controlled trial in adults aged 50 to 59, also known as the ZEST study. There were an additional 7 observational studies included in the assessment, which looked at real-world effectiveness of Zoster Vaccine Live. These studies were mainly done in managed care settings or using Medicare administrative data. This forest plot demonstrates the varying estimates of effect from the studies included in the analysis for this outcome. The x-axis represents the risks, odds, or hazards ratios and their 95% confidence intervals that were either reported directly from the study or calculated based on the reported VE. Also included on this figure are the VE estimates from each study and their 95% confidence interval, the mean age of study participants, and the mean follow-up time post-vaccination. Schmader 2012A was a randomized controlled trial in adults aged 50 to 59. And it is important to note that this age group is younger than the rest of the studies, which looked at adults aged 60 and older. Overall, we found that the estimates were relatively consistent among studies and demonstrated the vaccine to be protective against herpes zoster. So the type of evidence supporting the prevention of herpes zoster is type 1. For the 2 randomized controlled trials, there was no serious risk of bias and no concerns of inconsistency, given that the study population for Schmader 2012A was younger than the other studies. There were also no concerns of indirectness and imprecision. This led to an evidence type 1 for the randomized controlled trials. The observational studies were downgraded for risk of bias because outcome assessors were likely aware of the intervention received by participants, but there were no concerns related to inconsistency, indirectness, or imprecision, leading to an evidence type 4 for observational studies. The overall evidence type for this outcome was 1, following ACIP GRADE guidelines in which the overall evidence type for each outcome is based on the strongest evidence within that outcome. So moving on to outcome number 2, duration of protection against herpes zoster, looking specifically at 4 or more years post-vaccination. There were 2 randomized trials included for assessment. Schmader et al. Reported follow-up data from participants in the shingles prevention study 3 to 8 years post-vaccination in the short-term persistent study. Morrison et al. Reported follow-up data from participants of the shingles prevention study 4 to 12 years post-vaccination in the long-term persistent study. Both studies did have some limitations regarding their comparison groups. In the short-term persistent study, participants were unblinded during the study period and placebo recipients were eligible to receive the vaccine. Once placebo recipients received zoster vaccine live, they were no longer eligible to serve as controls, limiting the placebo group available for follow-up. In the long-term persistent study, there were no placebo controls since participants had already been unblinded. Instead, a comparison group was modeled using data from the placebo groups in the shingles prevention study and the short-term persistent study. And there were an additional 3 observational studies that were included in this assessment. So this forest plot demonstrates the varying estimates effect from the studies included in the analysis for this outcome by years since vaccination. So the top half of the forest plot includes studies that looked at VE during the first 4 years post-vaccination, and this is what was presented earlier for outcome number 1. The bottom half of this forest plot includes studies that looked at VE 4 or more years post-vaccination. These studies that looked at long-term protection were included in the GRADE analysis for this particular outcome. And so overall, we found that the estimates for protection 4 or more years post-vaccination to again be relatively consistent among studies and demonstrated that the vaccine was still protective against herpes zoster after 4 years, although not as protective as during the first 4 years post-vaccination. This graph shows the duration of protection of the zoster vaccine live against herpes zoster by year. And on the y-axis is vaccine efficacy or effectiveness, and on the x-axis is years post-vaccination. The 95% confidence interval for each estimate is represented by the error bars. The blue line represents estimates from the randomized controlled trials, which are the shingles prevention study, short-term persistent study, and long-term persistent study. And the other 3 lines represent data from large cohort studies. While these studies were done in different time periods and among different study populations with different age structures, overall, we see that they are consistent in showing a decline in VE over time. We determined that the 2 randomized trials had serious limitations in regard to the comparison groups as discussed previously, and thus were given an initial evidence level of 2. The observational studies were downgraded for risk of bias because, again, outcome assessors were likely aware of the intervention received by participants. But we found no other serious concerns and found that the evidence type for this outcome is 2. So moving on to outcome number 3, VE against post-herpetic neuralgia, or PHN. There were 8 studies that reported estimates for VE against PHN. There were 3 randomized trials included for assessment: the shingles prevention study, short-term persistent study, and long-term persistent study, which have been discussed previously. And there were an additional 5 observational studies included for assessment. This forest plot demonstrates the varying estimates of effect for VE against PHN. And the first 3 studies on this graph are experimental, and the remainder are observational. Overall, we found that the estimates for prevention of PHN to be consistent among studies, although there were some studies that had larger confidence intervals, and we will discuss that in the grade table. We deemed that Oxman 2005, or the shingles prevention study, as the only randomized controlled trial without major limitations. The short-term persistent study and long-term persistent study were graded as RCTs with limitations given concerns around their comparison groups, and thus were given an initial evidence level of 2. These studies also had large 95% confidence intervals and were downgraded for imprecision. Observational studies were downgraded for risk of bias because outcome assessors were likely aware of the intervention received by participants, and because PHN was likely underreported because diagnosis was often based on healthcare encounters and not self-report. But overall, we found the overall evidence type for this outcome to be 1. So now moving on to the grading of our harms outcomes. For our 2 harm outcomes, serious adverse events related to vaccination and reactogenicity, there were 11 studies that directly met our PICO question, meaning they had a comparison group that was either placebo or no vaccine. 9 of these studies were randomized controlled trials, and 2 were large observational studies. In 8 placebo-controlled trials with over 36,000 participants receiving Zoster vaccine live, there were no imbalances in serious adverse events between the vaccine and placebo groups. In 2 large observational studies, they found no increased risk post-vaccination for cardiovascular, neurologic, and infectious conditions studied, which are listed on the slide. Overall, we found no serious adverse events associated with Zoster vaccine live. There were additional studies that reported serious adverse events and reactogenicity related to the Zoster vaccine live that did not have comparison groups. However, we did include these in our grade analysis since they had at least 1 study arm that received the vaccine. So this was an additional 7 randomized clinical trials, 6 non-randomized clinical trials, and 5 observational studies. But overall, the findings are consistent with the findings from the placebo-controlled studies, with no serious adverse events found to be associated with Zoster vaccine live. So overall, there were 28 studies included in the grade analysis for serious adverse events related to vaccination. The 8 RCTs with comparison groups were given an evidence type of 1. The 13 RCTs with limitations included randomized trials with no comparison group and non-randomized clinical trials as shown on the previous slide, and these were given an initial evidence level of 2. The trials with limitations and observational studies were downgraded for risk of bias because outcome assessors were likely aware of the intervention received by participants. The overall evidence type for this outcome is 1. So there was additional safety data that we came across from case reports related to serious adverse events and OCA-related adverse events. That we wanted to share. In Merck's 10-year post-marketing review, they reported 13 cases of PCR-confirmed VZV rash caused by OCA vaccine strain. In clinical trials, 2 subjects with varicella-like rash and zoster-like rashes had PCR-confirmed OCA strain varicella. And there were an additional 7 case reports of serious adverse events related to Zoster vaccine live not included in the grade analysis. But none of these events have been substantiated as safety signals related to the Zoster vaccine live based on additional research or reporting through VAERS. So our final outcome is reactogenicity. There were 25 studies that reported data on reactogenicity, defined as injection site reactions or systemic reactions related to vaccination. Injection site reactions were the most common adverse event related to vaccination. 1 large RCT in adults aged 60 years and older reported injection site reactions among 48% of vaccine recipients compared to 17% among placebo. One large RCT in adults aged 50 to 59 reported injection site reactions among 64% of vaccine recipients compared to 14% among placebo. The range of injection site reactions reported among the remaining studies was 8 to 62%, with the large variation likely due to the large differences in sample sizes among the remaining studies. However, the majority of studies reported an estimate between 35 and 55%. 4 studies reported moderate to severe, or grade 3, injection site reactions that range between 0 to 4% of vaccine recipients. And this includes a post hoc analysis of the shingles prevention study that found that less than 1% of participants reported grade 3 reactions post-vaccination. 7 studies reported vaccine-related systemic adverse events, with reactions reported among 0 to 8% of vaccine recipients. So there were 25 studies included in the assessment for reactogenicity. 15 RCTs were given an evidence type of 1. Non-randomized clinical trials and observational studies were downgraded for risk of bias because outcome assessors were likely aware of the intervention received by participants. And this led to an evidence type 3 for non-randomized trials and an evidence type of 4 for observational studies. But the overall evidence type for this outcome is 1. So now I'll present the grade summary. But first, I'd like to provide some context on how to interpret the different evidence types. An evidence type 1 means that we are very confident that the true effect lies close to the estimate of effect. An evidence type 2 means that we are moderately confident in the effect estimate. And an evidence type 3 means our confidence in the effect estimate is limited. An evidence type 4 means that we have very little confidence in the effect estimate. And as a reminder, we are not measuring how good the intervention is, but rather how much confidence we have in the estimates of effect reported. So this is the grade summary for 1 dose of Zoster vaccine live compared to placebo or no vaccine in adults aged 50 years and older. The critical outcomes of herpes zoster, post-herpetic neuralgia, and serious adverse events related to vaccination were all supported by at least 1 large, good quality randomized controlled trial. And for these critical outcomes, the overall evidence type is 1. And in other words, our level of confidence in the estimates of effect of these outcomes is high. For our important outcomes, reactogenicity and duration of protection were assigned an evidence type of 1 and 2, respectively. So in summary, the findings were that Zoster vaccine live is effective in preventing herpes zoster and PHN, and no safety concerns of serious adverse events related to the vaccine were observed in real-world or clinical settings. And with that, I'd like to thank you for your time and attention.
Thank you for that very nice presentation. Why don't we go on to our last in this portion, which is Dr. Kalindis from GSK.
Good afternoon, ladies and gentlemen, ACIP members and Zoster Workgroup members. Thank you for the invitation to speak with you today. It's great to be back on the CDC campus, even if a little bit wet this week. My name is Romulo Kalindris, and I'm the Global Medical Affairs Lead for GSK's Zoster vaccine program. Today, I'll be presenting to you on behalf of a large team at GSK, as well as many study investigators, on the immunogenicity and safety of Shingrix in adults previously vaccinated with the live attenuated herpes zoster vaccine. Just as a reminder, a timeline as to where this presentation fits in the sequence of data that has been previously presented. The Zoe 50 and Zoe 70 Phase III clinical trials were previously presented at the June ACIP in 2015 and October ACIP in 2016. Earlier this year, in February, we presented a broad overview of HZSU safety with no major safety concerns to date. Today's presentation will focus on Zoster 048 study evaluating revaccination with HZSU of adults who have previously received the live attenuated herpes zoster vaccine. The following is an outline of the presentation. We will begin with a quick review of HZSU vaccine composition, as well as the context and rationale of why the revaccination study was conducted. Then objectives and study design, followed by a detailed look at the results, before ending with some important conclusions and key takeaway messages. Here is the composition of the non-live herpes zoster subunit vaccine candidate. On the left in blue, you see the antigen, which is 50 micrograms of glycoprotein E, the most abundant glycoprotein on the envelope of the varicella zoster virus, which elicits a specific immune response. On the right is the adjuvant system AS01B, which serves to enhance the GE-specific immune response. AS01B is a liposome-based adjuvant system containing the immunostimulants MPL and QS21. Synergistically, MPL and QS21 induce a stronger and long-lasting both humoral and cell-mediated immune response. To begin, some context and rationale of why the revaccination study was conducted. The live attenuated zoster vaccine, which I will refer to as ZVL or Zoster Vaccine Live for the remainder of the presentation, has been licensed in the US since 2006. Approximately 31% of US adults greater than or equal to 60 years of age have received ZVL. Vaccination with ZVL offers protection against herpes zoster with a vaccine efficacy of 51% in adults greater than or equal to 60 years of age. However, as has been published in the literature and was presented by Dr. Klein earlier, this protection wanes over time. Therefore, revaccination with a different herpes zoster vaccine may be required to obtain optimal and sustained protection against shingles. The Zoster 048 study was designed to generate immunogenicity and safety data in persons who received ZVL at least 5 years prior. Moving on to the objectives and study design. Zoster 048 is a Phase III prospective, non-randomized group match study which was conducted in the US. Subjects greater than or equal to 65 years of age were enrolled in parallel in 2 groups, the previous ZVL or no previous ZVL groups. As the name implies, previous ZVL were subjects who received the Zoster Vaccine Live greater than or equal to 5 years prior, and the no previous ZVL were those that did not receive the live vaccine. There were 2 co-primary objectives. The first was to compare anti-GE antibody concentrations 1 month post the second dose of HZSU between the 2 groups, and the second to evaluate safety and reactogenicity up to 1 month post-dose 2. There were also secondary objectives, which were to assess humoral and cell-mediated immune responses at different time points, as well as an ongoing safety assessment up to 12 months post-dose 2. Here you see a little more on the study design. Prior to vaccination, potential subjects went to a screening visit for eligibility, ZVL history, as well as matching variables. Based on this information, 215 subjects each were enrolled in the previous ZVL group and the no previous ZVL group. Subsequently, all subjects received HZSU at month 0 and month 2. In order to assess humoral and cellular immune responses, blood samples, depicted as the red circles on this slide, were taken at baseline or pre-vaccination, 1 month post-dose 1 and 1 month post-dose 2. There will also be a blood sample taken at the end of the study, 12 months post the second dose. As the study is ongoing, the results that will be presented today will be of the active phase or through visit 4, month 3. For participant enrollment, 822 participants were screened. for eligibility, ZVL, vaccination, as well as matching variables. The various matching variables can be seen in the box on the left. All subjects were matched according to age, gender, race, and as appropriate for medical condition. The medical condition matching occurred in hierarchical order as depicted in the box. The result was that out of the 822 participants screened, 430 subjects were matched and vaccinated, 215 in each group. There were 213 subjects who received dose 2 and completed the active phase of the study in the previous ZVL group versus 212 in the not previous ZVL group. Now to present the study results. First, a quick look at the demographics. The mean age of subjects upon receipt of the first dose of HCSU was 70.9 years, as depicted in the upper right of the far column. There was nearly an equivalent number of females and males enrolled in the study. All subjects were Caucasian, and the mean time in years since previous ZVL vaccination was 6.7 years. Now I would like to call your attention to perhaps the most important slide in the presentation, as it shows the results of the primary objective: non-inferiority of previous ZVL to no previous ZVL in terms of humoral immune response 1 month post the second dose of HCSU. What you can see is that the GMCs of approximately 48,000 for the previous ZVL group in orange compared to the GMCs of approximately 50,000 in the no previous ZVL group in purple, for a GMC ratio total value of 1.04 seen in blue, with an upper limit of the 95 confidence interval of 1.17, well below the preset criterion of 1.5 for non-inferiority. So clearly the primary endpoint of this study was met. Next, there were secondary objectives pertaining to the humoral immune response at separate time points. If you focus your attention to the graph on the left, you'll see the results for the Zoster 048 study, with the y-axis showing anti-GE antibody concentrations in logarithmic scale. On the x-axis are the time points pre-vaccination or baseline, 1 month post the first dose of HCSU, and 1 month post-dose 2. The orange bars represent the previous ZVL group, while the purple bars, or maybe pink on this slide, show the no previous ZVL group. What can be observed is virtually no difference between the two groups for any of the time points. Furthermore, if you look at the graph on the right, there are GMC results from our pooled ZOE 50 and ZOE 70 clinical studies. And for both time points, pre-vaccination or baseline, and 1 month post-dose 2, the results are remarkably similar to those of the 048 study. Cellular immune responses were also assessed by measuring GE-specific CD4 T cell frequencies. Again, if I focus your attention to the graph on the left, you can see this time the y-axis represents GE-specific T cell frequencies, again in a logarithmic scale. On the x-axis, you see pre-vaccination time point, 1 month post-dose 1, and 1 month post-dose 2. Again, the colors represent orange for the previous ZVL and purple-ish pink for the no previous ZVL. These CMI results are also presented as quartiles, with the checkered area being the first quartile and the filled color area being the third quartile, with median CMIs being the numbers above each bar. Similar to the patterns that were seen for the humoral immune responses, what we see here is similar T cell frequencies between the groups at all of the time points studied. If you turn your attention now to the graph on the right, you see the cell-mediated immune responses for Zoe 50, again with pre-vaccination and 1 month post-dose 2, which are similar to those in the 048 study. Now we will transition into the safety results, and first begin with a brief overview of how safety data was collected. Solicited local and systemic symptoms were collected for 7 days after each dose, while unsolicited adverse events were collected for 30 days after each dose. Serious adverse events and potential immune-mediated diseases are being collected and followed through the entire study period, or 12 months post the second dose. Again, as this is an ongoing study, the results presented today will be through month 3 analysis, or 30 days post the second dose. This graph shows serious adverse events as well as unsolicited adverse events up to 30 days post last vaccination. The y-axis shows the percentage of the reported event, and of note only goes up to 50% to better visualize the results, while the x-axis has serious adverse events, unsolicited adverse events, and unsolicited adverse events related to vaccination. The orange is the previous ZVL group, with the purple, the no previous ZVL group. What you can see is that for serious adverse events on the left, or for the unsolicited adverse events related on the right, there are no differences between the two groups. For the unsolicited adverse events in the middle, there appears to be a higher point estimate in the previous ZVL group compared to the no previous ZVL group. Although there is some overlap in the confidence intervals, we did look more closely into these unsolicited adverse events. And there are 2 points to make. The first is that the absolute number of the adverse events was relatively small, and these adverse events were widely dispersed over more than 20 system organ classes, with no apparent clustering or biologic plausibility. Lastly, and of note, there were no PIMDs or related serious adverse events reported from first vaccination up to 30 days post last vaccination. Now to share some results on the local or injection site symptoms within 7 days post-vaccination of any grade. On the y-axis, you see the percentage of the reported symptom, while on the x-axis, you see the symptoms pain, redness, and swelling. Again, the orange is the previous ZVL group, while the purple is the no previous ZVL group. The results are consistent with the phase 3 clinical trials, with pain being the most commonly reported injection site symptom in both groups. All symptoms were of a duration of 2 to 3 days, and the majority were mild to moderate in intensity. Now looking specifically at grade 3 solicited injection site symptoms, again the graph with the same formatting, except the y-axis only goes up to 30% in order to better visualize the results. Again, pain was the most common solicited injection site symptom for both groups, and all groups showed similar reporting for all symptoms. The median duration for these grade 3 symptoms was 1 day. For solicited systemic symptoms of any grade, the formatting again on this slide is the same, and the most commonly reported symptoms were fatigue, headache, and myalgia, all of which were reported similarly between both groups, the previous ZVL and the no previous ZVL, and all had a duration between 1 and 2 days. These results are also consistent with the phase 3 clinical trials. Lastly, for grade 3 solicited systemic symptoms, again here with the y-axis going up to only 30%, the 2 most commonly reported symptoms were fatigue and myalgia, and they were transient with a median duration of 1 to 1.5 days. So now I would like to wrap up with some important conclusions. Shingrix induced a strong humoral and cellular immune response consistent with phase 3 ZOE trials, regardless of previous vaccination with ZVL. There were no clinically significant safety differences observed between the study groups within 30 days post-dose 2 of Shingrix, and solicited local and systemic symptoms were also similar between the two groups. In summary, results of Shingrix phase 3 clinical trials, ZOE 50 and ZOE 70, demonstrated unprecedented age-independent efficacy of greater than 90%, even in those above 70 and above 80 years of age. And this high vaccine efficacy has been shown to persist through at least 4 years post-vaccination. Earlier this year, we presented the well-characterized safety profile of Shingrix with no concerns to date. Although solicited local and systemic symptoms are more common in the placebo vaccine than the placebo group, the majority were mild to moderate in intensity and of short duration. In addition, there was reassuring data, immune persistence data going up to 9 years, which was presented in February of this year. The results of the Zoster 048 revaccination study have demonstrated that having been previously vaccinated with Zoster vaccine live does not negatively impact the immunogenicity or safety of Shingrix. Given that the immunogenicity and safety results of this study are consistent with the ZOE clinical trials, we are encouraged that Shingrix may become an option for individuals who have previously received the live vaccine and may benefit from the high vaccine efficacy of Shingrix observed in previous trials. Thank you.
Thank you very much for that excellent presentation. Why don't we do some questions, comments now before we take our break? Dr. Reingold?
So I'm not sure whether this is for you or for Dr. Klein, but I'm curious, it's probably actually for you, in terms of the people who were enrolled in your study, whether any of them had had a history of zoster before they were enrolled, and if so, what the effects of the vaccine were in people with a history of zoster versus no history of zoster.
Yes, in our study, a history of herpes zoster was an exclusion factor, so they were not included in the study.
I could just speak to that too. We also excluded people who had a history of zoster.
Thank you. Dr. Moore?
Yes, while you're there, brief question. With respect to the Kaiser study, you mentioned the 5,900 cases that were borderline and that had a 86% positive predictive value and were excluded, but were included in your sensitivity analyses. I may have missed it, but how did they impact your sensitivity analyses?
Yeah, so that's a good question, right? So what we found is when we had those cases that we had essentially the same results as what we found with our primary analysis. Dr. Hunter?
Yeah, I just had an implementation issue about the Kaiser study. Did you really have 29% uptake of the zoster live vaccine in people over 50 who did not have to pay anything for the shot?
That is correct. But as you see, when we implemented the database prompt, it definitely went up quite a lot. The prompt is only for those 16 above, but yes, that's correct. It is a free vaccine, and that is what we've got.
Oh, so by bringing up the prompt, you're saying that it may be even more important to have the clinicians giving a strong recommendation, and it's not just the cost of the vaccine.
Oh, absolutely, yeah. All of our vaccines are free, and it was free prior to that. But yeah, absolutely, reminding physicians, and also the patients get reminded too with the prompt.
And I just have one last follow-up on that, which is the national data that we have on zoster vaccination uptake is based on 60 years and older, not 50 years and older, correct? Okay, so if you reanalyzed your data for 60 and older, it'd probably be higher than 30%.
Yeah, I don't know what the numbers, but you could see from the graph and that it is much higher than 29%. I don't know exactly what that is.
Okay, thanks.
Other questions? Oh, I guess everybody wants a break. Okay, so we will take a break for 15 minutes. If you could come back at 3:30 and we'll continue with the Zoster presentations. Thank you.